Good evening, everybody, and welcome to If Oxford. My name is Kathy. I'm the festival manager, and I will be your festival host for this evening. Let me start by welcoming everybody to celebrating the centenary of the discovery of insulin. All of tonight's speakers come from the Oxford Centre for Diabetes, Endocrinology and Metabolism, which is part of the Radcliffe Department of Medicine, who have sponsored the festival this year, and that's part of the University of Oxford. So I will now introduce our chair, Katherine Owen, who will take us through tonight's session. Over to you, Katherine.
Hello, everyone, and welcome to the webinar on celebrating the centenary of the first use and discovery of insulin. So most people have heard of diabetes, but before 1921, we had no real treatment for diabetes. And although a lot of things have changed over the last 100 years, in fact, insulin is still the major treatment for many people with diabetes who have type 1 diabetes or diabetes in pregnancy, and many people with type 2 diabetes as well. So tonight, we've gathered together a few people who either have diabetes, so they use insulin, or work with people with diabetes, or research into diabetes, to talk a bit about our reflections of 100 years of insulin and how it's affected our life and our careers. So first of all, I'm going to introduce the panel members to you. We have Amanda Adler, who's a doctor and the director of the Diabetes Trials Unit here in the Oxford Centre for Diabetes. So she works on clinical trials of new treatments for diabetes, including trials with very large numbers of participants. And she also sits on the National Institute for Health and Care Excellence. Kathy, could we just highlight Amanda for a second? Sorry. So welcome, Amanda.
Thank you. Thank you, Katherine.
We also have Nikkis Breslin here, who is a person who's been living with diabetes for 20 years. And when she's not working or being a busy mum, she's contributed a lot of her spare time to promoting patient participation in diabetes research and helping us with many of our involvement projects. Hi there. We also have Benoit Hastoy here, who's a scientist in OCDEM, who works trying to understand insulin production from the pancreas and the things that influences. And he's funded by Diabetes UK, which is one of the major diabetes patient charities in the UK.
Hi, everyone. Thank you very much.
Last but not least, I have David Jones here, who's a diabetes specialist nurse, who's worked with people with diabetes, both in the community and in the hospital, and helping them make the best of their diabetes. So welcome to all the panel. I'd like to go to Nikki first, if I can. And hi, Nikki.
Hello.
Could you talk to us for just a few minutes about what difference has insulin made for you in your life?
Other than the very obvious, I suppose, slightly cliched response of it's literally the difference between life and death, I think back to when I was initially diagnosed. I was misdiagnosed at first with type 2 diabetes. And before that, for about 3 months and for about 5 months afterwards, I was existing in DKA. And I guess the life from me just disappeared. I disappeared. I was a shell of a person who was sort of withering away. And I can remember the first week of using insulin and the difference that made. I started to reappear, and the color of my skin changed. My eyes were brighter, and I felt like a person, like a human again. Like the diagnosis I'd received wasn't a death sentence. So I empathize massively with people 100 years ago, because it really, really did change my life. It saved my life. And the difference it makes is, I think about, if I didn't have access to insulin, I wouldn't have two very healthy children who came into the world both weighing 7 pounds 8 ounces at 38 weeks, which I'm really proud of. It's not easy going, a pregnancy. And then outside of me, the difference it's made is that I have been able to meet other people living with diabetes, and I mean like all the types, which is incredible. And to have peer support and comfort and share knowledge, and to be able to get involved in research, whether that's telling people to look it up or telling people to have a go at participating, or participating myself, and see the contribution that makes on a wider scale, that's really huge for me. Because I think before diabetes came into my life, perhaps I wasn't living as much as I am now. You know, that's a really huge difference.
That's a really impactful thing to say, that diabetes can have a positive effect as well as the negative sides of the challenges of living with diabetes. I think you mentioned at the beginning you were living with DKA, so we should just say to the audience that DKA, which stands for diabetic ketoacidosis, is what happens to people when they are so low in insulin that they become sick and their blood sugars are very high, and it can be a life-threatening condition, actually. So
torture.
Thank you very much, Nikki, for that really powerful introduction to how important insulin is as a treatment. So I'd now like to go over to Amanda. So we're talking about diabetes. Everyone probably knows someone with diabetes, but actually, how do we diagnose diabetes?
Okay, Catherine, good question. So before figuring out who has a disease and who doesn't have the disease, you have to have a definition for what the disease is. So imagine there's a new disease that comes along. Imagine it's COVID. Well, before telling people that they do or don't have COVID, they need to decide what the criteria are. And the diagnostic criteria for COVID isn't the signs and symptoms, but of course, finding the virus in people. Now, diabetes is more challenging because diabetes is having a blood sugar that's too high. So it's pretty interesting to think about how high is too high. And so it's kind of like saying, how old do you have to be old? How fat do you have to be called obese? So someone had to get together and decide what the blood sugar level was that we would call diabetes. And of course, diabetes, unlike COVID, isn't a new disease. And in the old days, they would taste someone's urine to see if they had diabetes, because if the blood sugar was so high, people would pee it out. Well, we don't do that anymore. So, when someone set around to defining the blood sugar level, they approached it and they first said, well, we could just pick a number. Well, that's not very scientific, although it's done in medicine. We could find people with the highest blood sugar, say the top 10%. And we could say, okay, you have diabetes. But imagine back again to obesity. If we only took the top very few percent of people by weight, we wouldn't be getting people who are overweight. We would probably be getting people who are very obese. Why? Because the average person is heavy in Britain. So the World Health Organization thought about it, and they said, we would like to find the blood sugar level above which you have the problems associated with diabetes and below which you don't have the problems. And the problems that diabetes increase the risk for include stroke and heart disease and kidney disease and eye disease and nerves and even erectile dysfunction in men. So it seemed a very logical way to do it, except then the World Health Organization said, which of these many conditions do we pick? What if they all had different blood sugar thresholds? And the one they chose was eye disease or retinopathy, because it is more specific to diabetes. It's harder to get retinopathy in the absence of diabetes than the presence of diabetes, although it's quite possible to get a heart attack in the absence of diabetes. So going to a group in the United States, the Pima Indians, they were Native Americans living in Arizona, in whom they had excellent data on what the blood sugar level was and what the complications were. They picked a number, and that number is about 7 millimoles per liter if you're fasting. And that translates into about 11.1 if you've 2 hours after you had a very sweet drink. And so we diagnose diabetes 4 ways now. One is a high fasting blood glucose. The theory being, if you haven't eaten all night long and yet your blood sugar is high, that's probably abnormal. Or again, this 2 hours after drinking very sweet stuff, it's kind of like putting your pancreas on a treadmill. And the third way is that imagine like Nikki, you show up in an emergency room and your blood sugar is extremely high by anybody's criteria and you're in diabetic ketoacidosis. No one's going to make you come back in the morning for another diabetes test. That is diabetes, a high random sugar in the setting of signs and symptoms of diabetes. And lastly, over the last decade or so, we have another way. It's called hemoglobin A1C. And red blood cells in people with or without diabetes get sugar stuck on them as they go around. And although red cells really don't have much to do with diabetes per se, the more sugar that's stuck on them means that there was more sugar going around in the blood. So if a person has a high value, that also is the diagnosis of diabetes. And I guess I should say, in this 100th year of insulin, although many people like Nikki have diabetes because their bodies don't make insulin, we don't actually check insulin to diagnose diabetes. You think we might do it, but as a colleague said, we're the only group of doctors in endocrinology that don't actually measure the hormone of interest. Now, some people get their insulin checked, but it's high sugar. So thanks for asking me, and happy to answer any questions later.
I think it's fascinating how much science is behind what seems like a very simple thing to, you go to the doctor and you get told you've got diabetes, but the actual science behind defining that is extremely complicated. So thanks for summarizing that.
My pleasure.
Okay. So I'd now like to move on to speak to Benoit, who, as you recall, is our scientist working in the Diabetes Centre. And I'd just like to ask you very, very briefly to tell us a bit about what you do, what's your typical day, and also to tell us, how does the pancreas produce insulin?
Okay. Hi, everyone. So what is my typical day? I actually have several typical days. But I would say those are very important are the days where I collect the data, when I run experiments. And those days are usually the results of a week of work. And they consist in me being at the microscope for several hours or at the bench for several hours. Definitely they are very long days. But those days allow me to collect data, and they will help me to answer some questions, but more importantly, they will feed the next more puzzling questions. So it's an endless job. This is what makes it fascinating to me, and I keep going every day. But then to answer your second question, so I've put together 2 slides just to quickly help explaining it. And the question is, how does the pancreas produce insulin? So just can you, Katherine, tell me whether you see my screen? Yeah, all good?
Yeah, I do. Thank you.
So The pancreas is this organ that is here just localized behind your stomach. And this organ has many functions, but one of them is to regulate your glycemia, which is the blood glucose level. And in this organ, there is only a fraction of cells that will actually be involved in regulating your blood glucose level. And those cells actually agglomerate in small structure that we call islet of Langerhans. And we can take pictures. This is here an actual picture of an islet of Langerhans. And those cells that agglomerate, we can look at what they have inside. And by engineering them, we can actually show here in red the insulin. So what you are currently seeing is an islet of Langerhans with beta cells in red, which contain lots and lots of insulin. And what we can do when we want to look at how the pancreas secrete insulin, we can study these cells. And so with a lot of preparation, we can take individual cells, engineer them. This is what takes days and weeks of preparation, put them in the microscope and record them. And what you are going to see here is an actual beta cells. This is this little spaceship shape here. And within this beta cell, what you see in white, this is the actual insulin that we made visible. And in those beta cells, this insulin is stored in little bags that we call vesicles. And what you're going to see now in this recording is how a beta cell secretes insulin. And for this, at some point, I will tell you when, I have increased the sugar surrounding the sugar level surrounding these cells, and you will see the actual release of insulin, and that will appear as a flash. So here we go. This is the beta cell, and you see those flashes. This is actually the actual insulin being released in real time. And here I increase the glucose level, and you see the frequency increases a lot. And all those flashes is actual insulin being released just outside the cells. So what happens in your body is when the beta cell works well, they can sense the glucose level surrounding them and tightly correlate the insulin release outside the cells. This insulin will be released in the blood, and this is what will in turn will reduce your glycemia level. So this is how the pancreas, through the action of beta cell, can regulate and secrete insulin. I'm going to stop sharing this.
I think that's absolutely amazing to be able to see under the microscope actual production of insulin. I think that's such a beautiful picture. It really makes me, it's awesome science. And I mean, you could talk for hours about this. But basically, you're trying to work out what those influences on insulin secretion are, which might then lead to treatment changes in the future for people. Yes. So yeah, brilliant. Thank you. All right. Well, we better move on, and I'd like to come to David now. So David is one of our diabetes nurses who does lots and lots of the hard work with helping people with diabetes live well with diabetes. So David, can you tell us a bit about what your typical day is like?
Hi everyone. Our typical day is very mixed, and I think that's the best thing about the job. There is no typical day. Everything changes. One of the other part of the job is actually meeting people with diabetes for all different ages, from 18 upwards, either if they've been newly diagnosed or if they've had diabetes for years. Our job is mainly to be an advocate for them. So while they're in hospital, make sure that they're safe, making sure that they're comfortable with how their treatment's going with their diabetes, and actually are they on the appropriate treatment for them. So when we review people with diabetes, we're not just looking at people that are young. Sometimes we've got people that are elderly coming to the last months or weeks of life. So it's about working with them as well, and trying to figure out how they still want to have control of their diabetes and make it comfortable for them. We are teachers, we are learners. We learn lots from people that come in with diabetes. So we are not always the experts. Actually, we learn more from people that come into hospital with their diabetes than actually we do in textbooks. Every day is a learning day for us, and that's what makes it fantastic.
So Nikki talked, very clearly about what a big impact insulin treatment had to her, but it isn't a perfect treatment.
Is it a perfect treatment? With all treatments, there's often sometimes side effects with it. So it's probably as perfect as we can get it. And with research now, we're making it better and safer. I think insulin now people can use it and have more control for themselves of insulin, because there's lots of different types of insulin around, and they're not having to think about the next time they're going to eat, or, if they miss a meal, what's going to happen. There's so much more varieties of insulin around, and there's research all the time that's going on with new treatments. So is it the perfect treatment? At the moment, yes, but what will come around tomorrow might be even better.
Fantastic. I might bring Nikki into this part of the discussion as well. So Nikki, what are the limitations of insulin treatment for you? And how have things changed over the last 20 years since you were diagnosed with diabetes?
Oh, the change. I mean, what's lovely is I now use a very lovely small pump, and the insulin I use is a lot more effective than the Mixtard. I think it was human Mixtard 30 I had when I was first diagnosed, and I had to shake up the vial so it all mixed in together. And I had a 12.7 millimeter 29 gauge syringe to draw it up in. So as someone new, I mean, I describe it as being this long. It's not, that's exaggerating, but yeah, that was petrifying. That was not just because it's like the buildup of injecting yourself and drawing it up. Oh, there we go. Not just the buildup of drawing it up and injecting yourself, but the limitations, I think, are perhaps created by us, the users. We're kind of self-prescribing on a day-to-day basis with a combination of the knowledge that you guys give us and the support, but ultimately, crunch time, it's down to us, and it can only be as perfect as we and our knowledge are, really. And so it has some fear to it, what can go wrong, but mostly, fortunately, I think it works quite well with a few other bits of equipment.
So you're using quite sophisticated equipment compared to the beginning, aren't you now? So yeah. You've got an insulin pump and a glucose monitor. And we're leading towards much more automation of insulin delivery, aren't we? I mean, I might just bring Amanda in to the discussion at this point, because new technology in the treatment of diabetes is making life easier for people with diabetes, but it comes at a cost, doesn't it? Because all new treatments are more expensive. Could you talk a bit about that?
Sure. So Nikki's pump is an example of it's not that new, but so basically, Benoit will have told us that our bodies make a little bit of insulin at all times, and it doesn't last very long. And since its job is to rush ahead of the sugar, the carbohydrates you ate, and put it away in the cells, acting a bit like a key, unsurprisingly, you make more when you eat and less when you don't eat. But the body needs insulin between meals and all night long. And because insulin doesn't last very long, either you have to basically hang a bag of insulin off you that's constantly going in, which is in fact what a pump is, but it's not really a bag, is it, Nikki? It's very sleek. Or you have to use an insulin that the scientists added something to, so you only inject it a couple times a day, but it trickles in. And to check your blood sugar, if Nikki wants to know how much insulin she might need, because she knows that when she eats 4 biscuits, she needs about twice as much insulin as when she eats 2 biscuits. She historically would poke her finger. Yeah. And she'd see what her blood sugar was. And fingers and faces and other parts of our bodies are very sensitive. And so it hurts to poke your fingers all day long. So one of the examples of a technology that's we've seen in the last few years is something that sits right underneath your skin, and it measures the sugar, not in your blood, it doesn't go quite in your blood, but in that kind of liquidy fluid that you can see when you get a wound, and weepy kind of fluid, and that it just sits in there and checks what the sugar is, and it uses a calculation to estimate what the blood sugar would be at the time. So that's an example of a technology. Now, yes, there we're having a display of it. That's great. New things tend to be more expensive, and all that this health service asks, because it is, to be fair, taxpayer funded, and we don't want our government buying stuff that doesn't work, or we also don't want them buying it at a price that doesn't reflect the value. So things can be more expensive if they're better, but we have a system in this country where we determine if that's a fair, if you will, price. And so currently, people on insulin check their blood sugars. Many people with diabetes are not on insulin, and some, but not all of them, check their blood sugars. In fact, we discourage too much blood sugar testing for people on tablets, because whereas Nikki can say increase her insulin if her blood sugar is high, we don't recommend that people double up on their tablets. We might recommend they go for a walk or burn off some sugar. So blood glucose testing is in this country for people who are on insulin, and we're coming up with ways that are getting around poking yourself all day long.
And it's frustrating sometimes, I guess, Nikki, to feel that those treatments aren't coming fast enough, perhaps.
It can be, but from my perspective, and I know this isn't shared, I'd rather have something that is effective, that does work, that does represent good value, because I know that a lot of members of the diabetic community do feel like, we're a drain on resources. We hear that from people quite frequently. You've got diabetes, you're a drain on resources. And I think that's really unfair, because actually we really work really, really hard to keep ourselves well so that we're not a drain. It's very rare for us to put our hands up and say, hey guys, can we come in for an appointment? We need some help. And when we, so I think we do want everything that we utilize to represent good value for money, because it just means we can kind of clap back at those people saying we are wasteful. But I would much rather know that things work and that they're effective. And we're always waiting 10 years for a cure, so we've got patience.
So I'd just like to perhaps ask our organiser to bring Benoit back into the spotlight as well, so we're all together. And just to encourage anybody in the audience who's got a question to put it into the question and answer box, and we'll try and answer it. And I'd just like to spend the last few minutes of the session perhaps trying to look forward a bit. Is there anybody who'd like to speculate on how insulin, how treatment for diabetes might change over the next 10 or 20 years? Maybe Benoit, how will the work you do lead to new treatments for diabetes?
I wouldn't put it in as a new treatment, because the work I do is really trying to understand already the fundamental mechanisms that allow the cells to secrete proper amount of insulin, and trying to look at what we know from diabetes and see how these can interfere with this normal mechanism. Diabetes UK funded me to look at, for instance, we know that the diabetes is caused by lifestyle risk factor and genetic risk factor. And what I'm doing at the moment is looking at some genetic risk factor and looking at how this risk factor can interfere with the good functioning of beta cells. So I think very much at the moment, if the opening of my work, but that we are not talking about next year, we're not talking about 2 years, it might be decades or a bit. There is no linear progression. It can be very fast suddenly and getting slower, but would be to understand the molecular mechanisms that is associated with each genetic risk factor, understand how in the long term this drives the beta cell to stop working properly, and for clinician maybe being informed that patient with this certain type of risk, genetic risk, can be stratified or can be in certain group, and then they can adapt treatment accordingly. So it would be maybe helping on that, and knowing by understanding better how it works physiologically, we could also identify new drug targets, but that is something we can't really control how it comes.
Thank you. What about you, David? Where do you see treatments going? If you think about, over your career, how things have changed, and where do you see things going in the future?
I think, there's been a huge advancement in, for people with type 1 with technology, people with type 2, we've got other injectable treatments which aren't insulin, we've got more tablets as well. So, research is really going ahead where, and Benoit's right, it could take a couple of decades before we get the next sort of perfect treatment out there. I think for me, and what I'm trying to get to my team, is about how we can make things right now. So making sure that we've got the best knowledge and we share that knowledge, not just with people with diabetes, but other healthcare professionals, because actually my team's very small. We can't stay in the hospital 24/7. We need to give that knowledge to people that are going to be seeing. So that's doctors, nurses, midwives, anyone, that's our next job. And we could probably do that a lot quicker than the next sort of treatment coming through.
Thank you. We've actually got a question from the audience now, and they say, is type 1 diabetes ever brought on through lifestyle? I thought it was genetic. Often type 1s and others are blamed for their disease as if they brought it on themselves. Nikki, do you want to answer that one?
Yeah, I hear I hear you on the shaming side of things. That's a really hard one, because and that I think comes from people's misunderstanding of diabetes and that there are various types. On the genetic side of things, I certainly didn't create my type 1 diabetes. That's not something that I did. That's not anything I could have stopped. So yeah, but the more sort of better description would probably come from you, Katherine, on the genetic side of how type 1, is, if it is genetic, hereditary, etc. Yeah, sorry.
No, that's right. And in fact, nobody brings diabetes on themselves. even if you've got type 2 diabetes, you've got something wrong with your pancreas, and that's limiting the amount of insulin you can produce. So no one brings diabetes on themselves, and we're all very quick to judge other people's lifestyles without looking too hard at ourselves sometimes. So that's absolutely right. Type 1 diabetes is an autoimmune condition. Now, what's interesting is another potential new treatment at the moment for type 1 diabetes is to see if we can modulate that immune response that leads to the destruction of the beta cells that we've seen in Benoit's slide, and that might actually either help prevent diabetes, type 1 diabetes in the future, or it might help preserve some beta cell function for longer, which actually we know helps people with type 1 diabetes get better management of their diabetes. So I'm just looking into the question box again, and John has said, is there any way that we're able to identify people who are at a pre-diabetes stage as a result of COVID and stop them becoming diabetic? Amanda, do you have any comments about COVID and diabetes?
Well, we appreciate that there is sort of a two-way relationship such that people who have diabetes are more likely to do poorly if they get COVID compared with people who don't have diabetes and get COVID. But we're also seeing what we think is new diabetes after COVID. Now, there may be one thing to appreciate, and that is the very impressive recovery trial from Oxford University found that the first treatment that was clearly effective is dexamethasone, which is a corticosteroid that, guess what, causes diabetes. But the concern is it's better to have your COVID treated and stay alive than and diabetes is, if you will, an adverse effect. But when you think about it, we in this country don't even screen for diabetes. So we could figure out who was more likely to get diabetes. Why? Because with type 2 diabetes, their sugars start to go up. They start to go up. And before they cross that line in the sand I mentioned, it's just like you don't get old overnight. You go to bed as a 59-year-old, you wake up as a 60-year-old. Not that 60 is old, but so we could identify it, but we don't. And so the advice would be the advice for everyone, which is to get exercise, try not to gain weight. If you are overweight, think about losing a bit of weight, and those are and eat a healthy diet, which you don't really need a pre-diabetes test to encourage.
Thank you. And we've got a question in the box from Liz. Welcome, Liz. So you're pointing out it's very frustrating to constantly adjust things to stay within the safe blood glucose target. What's the prospects for more people getting access to technology? Well, I mean, Amanda may have something to say about this, but I know that we've got a lot of advocates in NHS England at the moment trying to improve access. So Amanda, I don't know if you've got anything else to add from the NICE perspective on this.
No, I do not. Although it's even more challenging to look at devices than to look at the effectiveness of drugs, because drugs pretty much stay the same, whereas devices are always being tweaked and improved. And so that can be a challenge. But yes, this country is being very proactive. Ever since Theresa May wore her blood glucose meter out on her date with Donald Trump.
Well, yes, thank you. And I think, as people working in the clinic, we have seen, phenomenal changes over the last 5 years in terms of access to glucose monitoring and more technology. And I feel really optimistic for the future of type 1 diabetes, both improving the access to technology and also in being able to offer, newly diagnosed people more different kinds of treatments like immunotherapy. And we haven't even had the chance to talk about education, which is actually a really key part of helping people live well with diabetes, because you can put all the technology you like and all the drugs you like into a system, but unless you know how to use that technology, you don't succeed. So that's also a really important thing that people like David are doing day by day. Now, as I expected, this 45 minutes has just sped by. So I think we better round up the talks today, and to say thank you so much for everyone on the panel for contributing, and just, I think, demonstrating the variety of people who contribute, work in our centre, or help us with our research. And just to say bye for now, and watch this space. We'll come back next year and tell you what new advances there are in diabetes. So thanks, everybody.
Thank you.
Thank you, Katherine, for sharing such an enlightening and interesting session, and to David, Nikki, Amanda, and Benoit for your insights into the different areas of diabetes that you work, live, and deal with. It's been an absolute pleasure to have you all here today. Thank you to our audience for coming in. Thank you all very much. Good night.